Hello friends, I'm sharing you an X-ray of a very young 17-year-old male patient with left hip injury. And X-ray shows fracture in the neck of femur, and the dates are very important because it has a chronic uh, treatment, and the neck femur fracture is very complex injury, and it requires a very judicious use of implants and surgical technique to get the best outcome possible. So it has fracture neck of femur, which require operative intervention. The operative intervention was done in 3cc screw, which causes cannulated cancer screws, were inserted as a standard treatment for this young chap, and the post-op X-ray is here, and the implants are placed as three screws, uh, but unfortunately the overall reduction is not anatomical. No doubt, the follow-up X-ray shows no signs of good union, and implants were not holding much, and there were signs that it's not going to unite and it's going to fail. Now we decided to salvage the hip and do the valgus osteotomy with a double angle DHS, and we did the subtrochanteric osteotomy, and a stable implant was placed, and we hoped that the fracture now unites, because we have converted the angle of fracture into more horizontal one to create an environment that better healing takes place. So friends, now the post-operative X-ray after valgus osteotomy looks very good. It's a solid fixation, and the angle of the neck of femur, the previous site, is now a little bit more horizontal, and the overall X-ray looks very good. So friends, the valgus osteotomy in few cases is a very good procedure, and we should all master and learn it in resource constrained environment, and in the, for young patients who want their hips to be saved for later. So no doubt it was gratifying to see this chap ultimately all fracture neck of femur and the osteotomy site were both healed very well, and the hip looks very good, and he's performing all activities of daily living, and we could salvage or save his hip. In another case, we also tried this in non-union of BC cervical neck fracture. So there is a almost vertical fracture at the base of the neck, and on the C arm also it is uniting but not have not united, and there is gap persistent. So we wanted to correct it and do the osteotomy as well to heal it. So we performed with passing wires in the AP and lateral view perfectly at the center, and then we perform the osteotomy, and then we fix it with double angle DHS. Now the osteotomy looks quite open, but gradually uh, it started uniting. Hello friends, I want to show you one minor complication that occurs during the procedure. Though it's not a big one, but when we make an osteotomy, we try to preserve the medial cortex. But sometimes when we close the osteotomy, the medial cortex is thin and it breaks. However, it doesn't change its outcome, but we should try to avoid this as far as possible. Thank you. Thank you very much.